just going to be palpating your wrist, and I'll just be holding it for 15 seconds, alright? Right. I've counted 18 beats. I'm going to multiply this times 4 to make up a minute, and this comes out at 72, which is totally within the normal range of 60 to 100 beats per minute. When I was doing this, I was checking for strength, regularity, and weakness. If there was any weakness or irregularity in Milka's pulse, this could be a sign of an abnormal cardiac activity. Milka, is it alright if I take your respiration rate? I'm just going to do it just how I did your pulse last time, but this time I'm actually going to get her focused on the fact that I might be taking a radial pulse because otherwise she may speed up her breathing. And I'm just going to observe how many breaths she takes for 15 seconds. Alright, it has been 15 seconds, and I observed that Milka breathed in about 4 times during this period of time, and we're going to multiply this by 4 to make up for a minute, and this comes to 16, which is completely within the normal range of 12 to 20 breaths per minute. Milka, is it alright if I take your blood pressure? Yeah. Okay, I'm going to walk Milka through the entire process with me so that she knows what's happening. First, we're going to ensure that her cuff of her sleeve is rolled up so that we can have access to the upper arm, and I'm going to place this blood pressure cuff on her arm. I'm going to ensure that I align this arrow here that says artery with her brachial artery, like so, and I'm going to secure the BP cuff with the Velcro strap. I'm just going to attach the dial to the BP cuff, and then I'm going to locate her brachial artery. I have located the brachial artery, so now I'm going to inflate the cuff until I can no longer feel her pulse in the brachial artery, and then I'm going to place the stethoscope over the brachial artery and listen to it. I'm now going to place my stethoscope on. And slowly release the pressure in the BP cuff and just listen for any noise. The first noise that I heard was at about 1:30, and that was Milka's systolic pressure. And then when I lost the noise, that was her diastolic pressure, and that was at about 80. This is within the normal range of a blood pressure because the systolic pressure should be less than 140 and the diastolic pressure should be less than 90. Milka would be considered hypertensive if her systolic pressure was higher than 140 and her diastolic pressure was higher than 90. Milka, is it alright if I auscultate your lungs? Yes. This means that I will have to place my hand inside your shirt to get a better, clearer listen to your lungs. So I'm going to listen to each lobe, one here, one here, one here, and here, on the front and 4 on the back for about 15 seconds each. I want to ensure that when I listen to each lobe that they're clear and equal and that there's no wheeze, stridor, or crackles. So Milka, I'm going to get you to breathe in and out. Take deep breaths and slowly as I'm listening to your lungs. Alright. Take one deep breath in. And another. And another. And one more for me, please. That sounded really good. I could hear Milka very clearly. Her lungs sounded clear and equal and there was no wheeze, stridor or crackles. I'm going to be demonstrating how to control a catastrophic hemorrhage on a patient. To do this, we're going to use a tourniquet. When you apply the tourniquet, you need to apply it 10 centimeters proximal to the wound. In this case, we're going to be applying it to the humerus because it's a single bone limb. To apply the tourniquet, we're just going to pull it up the arm and secure it firmly with the Velcro, and then you simply turn the windlass until it's tight and the bleeding stops. We're going to secure the windlass with this white strap, and then we're going to document the time. You want to tighten the windlass until the bleeding stops, or you lose the distal pulse, but in this case you'd be looking for a radial pulse. If the wound continues to bleed, we will apply another tourniquet proximal to the first. I'm going to be demonstrating hemorrhage control on this patient. First, we want to expose the wound. We can see here it's a bare arm, and we can determine the size of the wound. If necessary, we can apply saline to clean the wound, and we can also apply a moist dressing to compact it. We could apply an adhesive dressing if this wound was smaller, but as we can see to the size, this dressing here is going to work pretty well. So we're just going to fold it to the smallest possible size to entirely cover the wound and to apply maximum pressure. I'm going to secure the dressing with this bandage just by wrapping it around the arm and twisting and turning to secure it tighter and make sure more pressure is applied. If this does not stop the bleeding, all we have to do is apply direct pressure to the wound, and if that doesn't help, we can simply elevate, or alternatively, if these measures both don't work, we can apply indirect pressure to the armpit. I'm going to be demonstrating fracture management on a patient with a suspected right leg fibular fracture. I'm going to be explaining the injury to the patient and gaining consent to apply a splint and give him some pain relief. Excuse me, sir. I suspect that you have a right fibular fracture. What I'm trying to do is assess the injury to see what's going on. I'm going to provide you with some pain relief, and I'm going to get you splinted up. Is that okay? The patient has given consent. I'm going to expose both legs so that I can compare the right leg to the left and sort of assess if the fracture is really serious and what exactly is going on. While I'm doing this, I'm going to be asking the patient for some history about what's happened. I'd be asking him how the injury occurred, what sort of pain he felt, and what he was doing beforehand. So to assess this fracture, I'm going to be following the plus discs acronym. So first we're going to be looking at pain scale. The patient says he's in about a 7 to 8 level pain out of 10. There's no loss of function. He can move his foot, but it's painful. There's a bit of unnatural movement because he's in quite a bit of pain, so he doesn't really want to move anything. There's a bit of swelling, deformity, looks different to the other leg. It's a bit irregular because of this. There's no shortening, which is a good sign, no femur fracture. And there is a bit of crepitus on palpation. I don't think he's in shock. He seems to be very alert, and if there's not a lot of bleeding going on. I'm going to be assessing the cardiovascular and neurological intensity of this fracture. So we're going to compare the temperature of both feet to see if there's any damage to the lower limb. Pretty similar temperature. I'm going to be looking at sensation as well. You can definitely feel the whole foot. Feels just the same, just is still very uncomfortable to move. We're going to also be looking at cap refill. So pinch his toe, see how quickly it responds. If it wasn't responding quickly, we'd be looking at an arterial bleed or blockage. But because all of these are good, I don't suspect that there's any cardiovascular or neurological damage. We're going to be now looking at pain relief for this guy because we're going to have to splint his leg, and it's going to be very uncomfortable for him. So he's already said that his pain is about a 7 or 8 out of 10. So I'm going to administer him Internox because he's in this moderate to severe pain, and it has a very rapid onset of 2 to 5 minutes. Some of the contraindications of using Internox is that the patient may, if they are unable to obey commands, suspected pneumothorax. We've already determined that this patient is very alert, and that also the only damage they've got is to their legs, so I'm not worried about pneumothorax. No bowel obstruction, he'd be complaining of that or have some sort of idea of that. He hasn't been scuba diving, and he hasn't got any allergies to Internox as far as he's concerned. I would demonstrate with Internox here, but for this demonstration I'm just explaining what I would do. Some of the possible side effects that this man might experience if he has Internox is euphoria, flushing, sedation, nausea, and auditory disturbances. But our priority here is just getting this pain managed as quickly as possible so that he can be more comfortable. This is an oral analgesic, and he would have 5 deep breaths, and then I would assess the effectiveness. I'm now going to be splinting this patient's leg to support it, as we suspect that he has a right fibula fracture. So this is a cardboard splint. I'm going to provide a box splint for him. I'm going to place this towel inside the splint to provide a bit more comfort and stability, because cardboard can be pretty rough and uncomfortable, and it just makes it a bit sturdier. I'm going to secure this splint on his leg with some bandages. I'm just going to place it underneath before I slide the splint underneath his leg. So I'm going to gently lift the foot and leg from the ankle. Hopefully by now pain relief is kicked in, so this was not super uncomfortable for him. And I'm going to very gently secure these bandages around each end of the bone. This is just to prevent any movement. We want to make it as sturdy as possible, and we don't want any more discomfort for him. But also we want to reduce any more damage caused by moving this leg. So in this case, I'm going to secure it at the ankle and at the knee. And there we go. Got a box splint. Patient has been given pain relief, and now we can get him on the mend. I'm going to be demonstrating how to apply a C collar onto a patient. First, we need to look at the indications to use a C collar, and we need to follow the nexus rule. This means the patient needs to have no evidence of intoxication, posterior, midline, cervical spine tenderness, no distracting pain, no neurological deficit, and an alert mental status. I'm going to ask my patient for consent with applying the C collar. Excuse me, sir. We're going to apply the C collar to your neck. Is this all right? The patient has given consent, and now I'm going to ask Milka if she can please stabilize the patient's head. We're just going to gently raise it and place this towel underneath. And now we're going to measure the C collar. To do this, all I have to do is place my hand in the space between the jaw and the clavicle. I can see that my hand fits there in that space, and I'm going to place my hand on the collar and measure it like so. The C collar is already at an ideal size, so I don't need to adjust it, and I'm just going to quickly bend it so that it'll fit easily around the patient's neck. I'm now going to apply the C collar to the patient. Milky, can you please gently lift the patient's head once more? The C collar is now applied to the patient. Some of the risks when using a C collar is that it can exacerbate the injury over time if worn for a long period of time, and can cause pressure sores. I'm going to be testing the suction unit on a patient in the lateral recovery position. To initially test the unit, we're going to turn this dial full bore. We're going to obstruct the tube until the light reaches 350 millimeters of mercury. Works perfectly. To use the rigid catheter, you've got to turn the machine on again. You insert it into the patient's mouth, but only as far as you can see. Move it in a circular motion as you're moving out. You only suction on the way out, and you do it for a maximum of 10 seconds. Some of the complications of using the suction unit is that it can cause aspiration, soft tissue trauma, hypoxia, bradycardia, and vomiting. The rigid catheter should not be used in a moving vehicle as it can cause this soft tissue trauma. I'm going to be demonstrating some airway management techniques with an OPA and an EPA. Some of the indications to use an OPA is that the patient has a GCS score of less than 8 and a verbal response score of less than 2. We're going to measure it appropriately by simply placing it against the mouth and the mandible, and it fits very well, so we know that it's going to be a perfect fit for the patient. We're going to gently place it in the mouth, following the curve, and then twist 180 degrees to sort of lift the tongue and scoop it to prevent it from falling back into the airway. Some of the complications when using an OPA is that it can damage the oropharynx, can cause vomiting, and can block the airway. This is an NPA. We're going to measure it to fit the patient in a very similar manner to that of an OPA by placing it by the nostril to the mandible, and again, it works perfectly. It's a perfect fit. We're going to lubricate it with a water-based lubricant, but I've already done this, and this is just to make it easier to insert and more comfortable for the patient. We're going to gently insert it into the nostril, and then if there's any resistance, all you have to do is twist it 180 degrees and try again. If this resistance continues, you can use the other nostril. Some of the benefits when using an NPA is that there's no gag reflex, so no vomiting, and you can use it on a patient with a high GCS score. Some of the contraindications of using an NPA is that it shouldn't be used on a patient who has facial skull fractures, nasal polyps, or nasal bleeding. I'm going to be demonstrating how to administer oxygen to this patient. This is an oxygen cylinder. We can tell because it's identified as an oxygen bottle, so we know we're using the right product. I can see there's no damage to the cylinder, so it's safe to use. This is a Bodac seal and regulator. Again, I'm going to check for any damage. I don't see any, so I can attach this safely to this oxygen cylinder. To do so, I'm just going to slide it over the top of the cylinder. I'm going to turn on the cylinder, and I can see this dial rising on the regulator to 1,000, so we know we've actually got a product in the bottle. I'm going to be administering oxygen with the nasal prongs, so I'm going to insert this here, and I'm going to put it to 3 on the regulator, because nasal prongs, the oxygen in nasal prongs needs to be administered between 2 to 4 litres per minute, and it's at 28% oxygen saturation. This is because the patient can also breathe through their mouth, so it's not fully concentrated. To put the nasal prongs on the patient, we're just going to insert them into the nostril and tuck it like so behind the ears. This patient is now being administered oxygen. The patient has been administered oxygen, so I'm now going to remove the nasal prongs and begin to flush out the oxygen from the regulator. To do this, I'm going to first unplug the nasal prongs, and I'm going to turn off the cylinder. I'm then going to let it flush out here because the regulator is still on, and now that I can't hear any more noise, I'm going to slowly turn it off. I'm going to be demonstrating how to use a bag valve mask. First, I'm just going to check that if there are any leaks. Just going to cover up the valve. There's no leaks, so it's safe to use. I'm going to test my reservoir and fill it up. Again, no leaks, so I'm free to assemble the bag valve mask. I'm going to attach it to some oxygen at a flow rate of 10 litres per minute. I would turn on the oxygen, but we need to conserve it for other students. Before I use the bag valve mask on the patient, I'm going to perform head tilt chin lift. And I'm going to insert an OPA. It's just to maintain the airway. I'm going to apply the mask, nose first, and I'm going to use a CE grip because I'm a single user. I'm going to ventilate very gently every 5 to 8 seconds, and I'm going to watch for chest rise. I'm also going to check for gastric inflation, because if that does occur, I will need my offsider to assist me. To prevent gastric inflation, all you have to do is place your finger on the cricoid ring and massage it anteriorly to posteriorly to move the trachea posteriorly and compress the esophagus to prevent gastric inflation. I'm going to be demonstrating how to use the MRX monitor. So first I'm just going to turn it around to show the batteries. I'm just going to unclip this pocket. These are the batteries here in the back. There's a little button on the top and I'm just going to press it and see the green light. There are several green lights, so I know there is some battery. If I had to take this battery out and charge it, all I have to do is squeeze it on both sides and it comes out and can be charged. I'm just going to replace the battery again, and then I'm just going to reclip this pocket back to the monitor. So we're going to turn on the monitor by putting it on the monitor mode, and we're going to put it into an operational check. So to do this, I'm going to press this button down here. I'm going to select Other, and then I'm going to select Operational Check. I'm going to select Run Operational Check, and I'm going to listen to what it tells me to do. The operational check is now running. It's telling me to set it at 150 joules. I'm now pressing the charge button, and now I'm going to shock.
Shock delivered.
This shock would have been delivered through the test load. I did hear it say shock delivered, so I'm going to select yes. And now the operational check is running. So while it's running, I'm going to take you through the components in the side bags of the monitor. In this bag we have the SpO2 finger monitor, we have the ET-CO2 consumable, and we have the non-invasive BP cuff. I'm currently wearing the 3-lead ECG cable. In the rear compartment, we've got the 12-lead ECG cable, we've got an additional test load, we've got some GTN, we've got a bag here with a razor and some aspirin, we've got an additional BP cuff, and we've also got a pediatric BP cuff and an extra roll of paper for the ECG printer. In this other side pocket here, we have the defib pads, as well as the CPR puck and the test load. To change the paper, I'm just going to pop this in here. When the monitor is turned on to AED mode, it automatically defaults to defib pads. And now we're just going to exit the operational check. I'm just going to turn it on to monitor mode, but that's just to check that it's still on.
Analyzing
I'm
heart
going to turn it on to AED
rate. Do
mode,
not touch the patient.
and I'm just going to
No
remove
shock advised.
the paper. I'm going to switch to 50 joules for this example, but usually you would have it on 150 joules if you were shocking an adult patient. We're going to test the defibrillator. So we're just going to press charge, and we're going to deliver a shock. Now that I have performed performed a shock. I'm going to disarm a shock, so we're going to press charge. But rather than pressing the orange shock button, we're going to press this button here and disarm the charge. Alright, we're now going to switch to the monitor. Okay. We're going to adjust the volume. And we're going to turn the alarm off. I'm going to change the volume now on the QRS. This volume can vary between very soft and very loud, but I'm just going to choose medium. And now we're going to change between the leads. All you have to do is press this button here. It's pad 1, 2, 3, and that is the pads. But for this, we're just going to leave it at pad 2. I'm going to adjust the ECG size by selecting displayed waves. I'm going to select wave 2. And we're going to select pad 3. We're going to make it 4 times the size, and I'm just going to adjust that there. Alright. This is the non-invasive BP cup, and to operate it, you press this button down here. I'm going to be demonstrating how to perform a resuscitation with CPR and the use of an AED. We're going to be checking for dangers. I can't observe any. We've just got our patient here unconscious on the floor. I can't see any bystanders. We've got our PPE gear on, our gloves and our goggles. And now we're just going to respond to the patient. I'm going to assess this man's verbal response and pain score. Excuse me, sir. Sir, can you hear me? This is the ambulance here. Sir, are you all right? And it's not responding to any verbal prompts. If I pinch his arm and shoulder quite hard, he's not making any noise whatsoever. He's not really responding to the pain. I'm going to perform the head chin tilt to open up the airway. I'm going to check for breathing. This man is not breathing. Can you please start CPR? I'm going to call for backup. This is AUT1 calling comms.
Copy.
I'm confirming an R49 and requesting an R50, please.
Copy.
Thank you. Alright, I'm going to attach the AED.
Analyzing heart rhythm. Do not touch the patient. Shock advised. Charging. Stay clear of patient.
Stand clear.
Deliver shock now. Press the orange button
Shocking.
now.
Stand clear.
Shock delivered.
Right, can you please start CPR?
Start CPR.
And I'm going to attach oxygen to my bag valve mask at a flow rate of 10 litres per minute. Can you please let me know when you've done 25 beats, and we'll just count down. I'm going to use a CE grip, and we're going to do 2 breaths every 30 compressions.
25, 26, 27, 28, 29, 30.
Okay, I'm going to be looking for chest rise. I see chest rise. I see chest rise again. Okay, begin again, please. We're going to be aiming for 100 to 120 compressions per minute. During this time, I would try to gain a history of the patient, but we don't have any bystanders. We'd be asking what happened, a history of their medical life and their general habits, and if anything external caused this, or if this is an internal cardiac arrest. We're going to be checking for good recoil depth, and we've already checked for chest rise. Every 2 minutes, we're going to be swapping over. So in that time, we're going to be doing 4 cycles of 30 compressions and then 2 breaths.
25, 26, 27, 28, 29, 30.